And as Sachin is my friend, so this is a chance. Thank you. So, Sachin, I'll just ask you one thing. Just a moment. Okay, can you see it now? No? Right.
Yes, yes, it's working.
So I must first thank Dr. Kotkar sir and Dr. Sachin Sandorkar for this opportunity. Actually, when he spoke about the topic, I said, Bapre, this is a big topic, drug errors in anesthesia, which was a problem. But then I tried to turn it to opportunity by reading, and I will be learning here with all of you. So thank you for that opportunity. I say Nanded. Now, when we read about medical error, so many things come in our mind. First, I think it is the law, then death, then abuse, infection, anaphylaxis, mistake, judgment, what went wrong. Will I be able to continue with my practice? Will I stop? So many things come to our mind when we just read this simple word medical error. To begin with, I'll ask you, how many us have made a drug error so far? Can I have a raise count, raise hand option? Not able to keep a track here, but I can ask, definitely many of us have gone through this, but how many, and many of us have even got away with it. Have we reported it? No, not many of us have reported. So to begin with, I would like to first tell you of my case, the mistake I made and what I learned through my mistake. Now, this was a routine OT. I had to anesthetize a patient for radius ulna. I went to the operation theater and I found that the patient had plaster on both the hands. So I confirmed with the OT anesthetist and asked him which limb is to be operated. So he said, Madam, it's the right hand. So I gave the block, started the anesthesia was fine, and we started even opening the dressing and scrubbing. When the surgeon came, he looked annoyed. In fact, he didn't speak a word then to maintain the OT atmosphere, and then later told us that this was a minor injury and he wanted to operate on the left hand. So because the plaster was on the both hand, I also confirmed only with the OT assistant and not with the patient. So here I learned my mistake. What mistake I made is I asked only the OT assistant. I didn't check the X-ray. I didn't ask the patient herself which hand is to be operated. So after this mistake, we discussed in the OT, and later on the date till date it happens like when I enter the OT, I ask the patient, the assistant enters, he asks the patient, surgeon enters, he confirms the site. So with our mistake, we learned. So this is a good way to move ahead. Second case I would like to tell you all is there was a mother, Rh negative mother, who delivered an Rh positive baby. Now the trained nurse was instructed to give anti-D immunoglobulins, injection Rogam, IM, to prevent Rh isoimmunization. She was very well versed with it. 10 minutes later, the mother developed difficulty in breathing and suddenly stopped breathing. Immediately, code blue was triggered. Patient resuscitated and ventilated, put on the ventilator. The patient was fine, but then what went wrong? 6 hours after all this happening, the in-charge sister, she spoke to the head sister and I just gave her her whatever was in mind. She opened the fridge and checked which drug was actually given. To her surprise, injection Rogam was still there. So what was injected? She opened a bin of sharp beans, the waste, and there she found, just have a look, she found injection rocuronium. So injection rocuronium was given in place of injection RHD immunoglobulin, that is Rogam. So because of the look alike, the sound alike, and placement in the fridge, she made a mistake and drug error. But now because she came forward with her mistake and everybody knew what the problem was, the patient could be settled for 24 hours. The patient was ventilated and discharged next. So this is one case. Here is a third case when what happened is a 23-year-old patient, ASA grade 1 for routine appendicectomy. The anesthetist advised, please give the sedation, injection midazolam. Patient, after receiving the injection, developed breathlessness and twitchings all over the body. And it was found to be succinylcholine 12. Immediately, the patient was induced, intubated, taken over controlled ventilation, and surgery was uneventful. So and post-op, even the patient was extubated. But because there was presence in the OT And instead of giving it to the assistant, if self medication would have been done, then maybe this error would have been not occurred at all. Recently, we all have heard about this case where 5 days before surgery in PGI indicate occur because suspected drug here is the propofol. Because it was from a common drugstore, this has come into picture. Now, so many errors are occurring here every time. So what are the actual drugs? It can be a wrong drug, as in the case of Rogam and Rocuronium. It can be a wrong route, IV, IM, subcute, epidural, anything. Wrong dose, wrong patient, wrong side, as I enumerated my patient, wrong time of the drug, and a contraindicated drug which is not supposed to be given, but it has been given. As you can see in the picture also, Medzol 200, Medzol 40, Medzol 400. There is a variety of drugs, but everywhere it is Medzol. So big confusion in the name itself. So friends, we as anesthesiologists in our career, clinical career, may inject up to 500,000 of drugs. And so the chances of making an error are very high. Moreover, an anesthetized patient would not tell you or show you or tell you actually, or you can even not see that this is developing, that is developing because the patient is anesthetized. What we have to look into this is the bronchospasm. We may come across directly bronchospasm, the hypotension, arrhythmias, and maybe cardiac arrest directly. And we may not get even time to correct. And that is why increase in morbidity, sometimes mortality, then financial burden, not only on the doctors, but the hospital, and things which happen which cannot be reversed. So the main mantra here should be Daksho Rakshati Jivitam, which means one who is alert can save a life. Yes, alert before injecting, alert after injecting if any changes are happening. So everything come together can save a life. Now, when patient gives consent for anesthesia, the patient trusts us. The patient trusts that our training is adequate. Whatever we learned in the medical college is adequate. We are competent. Our judgment will be uncompromised. So friends, it is this responsibility for which this concern and this consent and trust for which we are responsible more than the what will happen medically. So this is very important. Coming to the incidence, as you can see, there are few studies in here. Webster al, they found the incidence is overall 0.7%. They found that incorrect dose and substitution of the drug was the main cause of errors in their study. Sagakuchi et al. Found syringe swap as the main cause of drug errors when they studied in 2007. In 2005 and 6, in a study at South Africa, it was on misidentification of the drug. The drug ampule which is to be given was misidentified. Cooper et al. Found in 2008 that inadequate experience training is the main reason for drug errors. So overall incidence was found is 0.7%. That is 1 per 133 anesthesiologist can commit an error. So not very high, but considering our own self, giving so many drugs at a time, we are prone to make an error at this extent. Here also it is seen inadequate experience accounts to 5% of the errors. Inadequate familiarity with the drugs is 6. Poor communication. What you are telling, give this drug. What the sister or the assistant understands is different. Hurry. You should not be in a hurry, and because hurry is one of the major causes of causing a drug error. Dependency on the personnel in the OT, poor labeling of drugs, fatigue, long hours of working. Then you want to go for a case, there are high chances you commit an error. So this is an overall incidence. Going back to the history, in 1947, that is exactly 75 years back, in the UK, first system failure was reported. Now here, it was a case of Woolley and Rowe, where 2 patients were left paraplegic after undergoing spinal anesthesia. It was found that the paraplegia was due to the local, the phenol. which seep into the local anesthetic drug through the microscopic cracks in the ampule. Very difficult. That time, LA ampules during sterilization process, it was found that a batch of spinal needles had not been removed from the bath of acidic descaler and boiled again in distilled water for reuse. So the drug, and why this all happened? Because the person who was going to do this had taken a call off. So he was sick. So major example of a system failure reported 75 years back. Second case, here again a fatality was reported when the sister was advised to increase she increased the epidural flow rate directly to 125 ml per hour. And actually she was just supposed to give an IV bolus. She was intended to give an IV bolus and she increased so this is miscommunication, overdose and wrong route. Then that again was a fatality. For cases of leukemia, intrathecal vincristine was given instead of methotrexate. Changes in the timing of heparin, many other drugs are reported, but these are the few I put up. Now, medico-legal consequences. With increasing awareness, once the error has occurred or reached the patient and caused harm, the doctor is helpless. It's very difficult to reverse things. She adds to the significant cost of medical treatment, increases morbidity and sometimes mortality. What usually happens also, if not mortality? Awake paralysis. If awareness is not well taken care of, patient reports, I was paralyzed, I could hear doctors, I could listen to their talk, what they were talking about, I could listen to the drilling machine, I was awake and paralyzed. So this is very common medical legal case which comes to us. Then allergic reactions. The patient had informed, still developed, patient had not informed, and anaphylaxis occurs. This is again okay. They come for a minor case, some antibiotic reaction according to them occurs, and patient lands up in an anaphylactic death. We'll be surprised. Actually, it is a chilling reality that drug errors is the number 3 cause of death in the US, claiming 40,000 lives each year. Now, actual definition. What is a medication error? A medication error, please look into every word, is any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of healthcare professional, patient, or consumer. Right? Such events may be related to professional practice, healthcare products, procedures, system, including prescribing also. I have prescribed pneumococcal vaccine and patient is been given pancuronium. So prescribing, order communication, product labeling, packaging and nomenclature compounding, dispensing from the pharmacy to distribution, administration, education, monitoring and use. So in fact, at every level, the drug error can occur and we may be held responsible. Practically, now let us come to things. So pre-operatively, where we are into picture, syringe swap, very common. It can be an overdose, dilution error, particularly with adrenaline or antibiotics, wrong route of administration, omission. The patient was supposed to receive some drug or heparin before a surgery, it was to be given, antibiotic prophylaxis was to be given, tranexamic acid was to be given, and I completely omitted it. And then it caused complications. So that is one reason. Underdosing, particularly, this is with pediatric patient, wrong calculations. So preoperatively, so many things can happen. Now this index is provided by National Coordinating Center for Medical Error. Error and prevention also, right? Reporting and prevention. Here, as you can see, there are 9 categories. Circumstances or events which have the capacity to cause error, but no error is caused. To give you an example, I have a COPD patient coming for a surgery. I want to give, suppose dexamethasone in this case, or Derifile. I look at my trolley and I pick up the drug. I see it is there. Next to it, I pick up by mistake, I pick up fentanyl. So there was a very high chance of an error, but because I saw it, then it was avoided. So that comes under category A, which will say that circumstances or events were there, but error did not reach the patient. Now category B, an error occurred, but the medication does not reach the patient. I aspirated 2 syringes of 5 ml on the trolley. I had to, like in the second case we saw, instead of giving sedation, midazolam, scoline was injected. So error occurred and reached the patient. Third is error occurred that reached the patient but did not cause, just a minute, I have to shift this. An error occurred that reached the patient but did not cause patient harm. Many a times overdose occurs, we inject intrathecal overdose, and then we have to just observe. No harm is seen here. Okay? An error occurred in category D that resulted in the need for increased patient monitoring but no harm. Many a times this comes across where respiratory depression is seen or patient feels nausea, there is headache post-panel. So we observe and monitor. No patient harm as such. Category E is categorized an error occurred that resulted in the need for treatment and intervention and caused temporary patient harm. So this can be the rocuronium and rogam case. Category F, an error occurred that resulted in initial and prolonged hospitalization, temporary patient harm. G comes under error occurred that resulted in permanent patient harm, like the patient who developed paraplegia after the spinal anesthesia. An error occurred that resulted in near death is category H. An error occurred and resulted in death is high risk, that is category 9. This is a pie chart where again it is, as I have already enumerated, in the category A where there is no patient harm, drug error has occurred but no harm. B, C, D, the harm has occurred, error has occurred. Sorry, there is no harm. E, F, G, H, error and harm. And last is error and death. So just a pictorial representation of the same categories. Now in our case, before administration of anesthesia, preparation of drugs, as we have learned during our curriculum, we aspirate the drugs, label them, keep it on the trolley, arrange them in a sequence taught to us. So what can go wrong when you're doing all this? Look-alike drug ampules are very common nowadays. Unlabeled syringes, not checking label, including the expiry date prior to administration. Different concentration of drugs. Simple bupivacaine 0.5, 0.25, adrenalized, non-adrenalized, incorrect dilutions. So this definitely makes a difference. Very, very common, look alike or sound alike. From a distance, you cannot identify, and the legibility or the font size is so small, it is very difficult to identify. Many a times, or it is actually advisable to keep a lens, because now in the mobile phone, we have zoom option. Read it properly, look alike, and then more than the company, more go towards the actual pharmacological name to avoid these errors. Various way to highlight in OT, it is kept like, you can just read out the last, it is tab glycomet and tab glyolate. So that is the difference, sound alike and look alike drugs. So better to identify them in our OT. Tabular form, you can put it, highlight them and paste it in the OT before going through it again. Look alike and sound alike. Existence of confusing drug names is one of the most common causes of medication error. Medzol, 40, 200, 400. So difficult to identify. And when we are ordering someone or telling someone else to give the drug, it becomes even more difficult. With thousands of drugs currently in market, potential for error due to confusing drug names is significant. And what are the contributing factors? Illegible handwriting, incomplete knowledge of drug names, new available products coming every day, similar packaging or labeling, similar clinical use, similar strains, dosage, frequency of administration. Now this was pre-operative part. Coming to the administration of drug, near misses. As I said, I had to avoid opioid in this patient, and I really just avoided by the chance ki instead of fentanyl, I just saw that the drug is wrong and I switched over to my original drug. One more, I can give you an example in this case. Now in a OT complex, when you are giving multiple patient or surgeries are going on, and maybe 2 or more patient needs blood at the same time. So in our one example I can quote here is, there are 2 patients. I had ordered blood for Mr. Pramod Shinde. And that day, Another OT had a patient who was again Shinde, but it was Prabhakar Shinde. And both of us asked for blood. So the blood comes. I just see Shinde, A positive water. But before starting, I read again and I find that it is not my patient. And it is so it is near miss. Very, very close to making a grave mistake and error. Wrong patient. Again, same example can be quoted here. Prabhakar Shinde and Pramod Shinde. Wrong person, wrong patient. Incorrect doses, particularly in pediatric cases or the calculation. Drug personnel for preparation and administration of the drug. Yes. Sometimes we tell when we are in hurry or we have to hold the mask, there is other risk. Then we tell the assistant, inject this drug, aspirate and inject. So I will just suggest here, we all of us know that better to aspirate and then give them to inject. Syringe swap, very common if they are not labeled. Wrong route of administration, incorrect timing. Now here we can be blamed for not giving the antibiotic prophylaxis before the tourniquet is applied. Or injection of pause is second, heparin timing. So incorrect timing, removal of the catheter and the heparin timing, omission, substitution and repetition. Sometimes they ask us to repeat, inject inside. So we have to be careful with that. Now recording of the drug delivered. Yes. Whatever has been given has to be documented. Second, adverse event, if at all occurred and not recognized, is even more grave. Rash. Sometimes even the BP drops, the alarms are switched off because you don't want to get disturbed. Somebody else, if not you, has lowered the volume of the alarms. Then again, that is a grave mistake. So adverse events can occur this time. Reluctance among doctors to admit the errors. It is very, very difficult. Even when I made my first mistake, I did not tell my friend. But over the period, then because things have to be changed in OT and audit happens in our OT, that time also it will be always like, I don't want to, we should not blame who has done this. Actually, what has gone wrong and what can be done. So that is very important. And failure to report, even at higher levels. We will come to this again. Own your error. Yes, I made a mistake, so that it can be corrected. If we don't own our error and tell others, reporting is different, but first I should own it. That sister, because she opened up which on the fridge and saw that Rogam was still there and opened the sharp bin tin and found injection Rocurandim. She came up with a roller, informed the higher nurse, and so it was correct. These are again few definitions, quite interesting again. Errors when actions are intended but not performed. Like I said, there are multiple here again. Mistakes, errors in planning actions. There is an obese patient, very high chances that the jaw may fall, and I had failed to put the airway on the trolley. So that is a mistake. Knowledge-based error. I know the antibiotic prophylaxis, the tourniquet hand has to go before the tourniquet is raised. So that is knowledge-based error. Rules, good rules and bad rules. We have to follow protocols, timing of heparin. So we know knowledge. Mistakes is we have the knowledge, but we are forgotten or we are not doing it in the right. Other is skill-based error. Now here, there is nothing to be learned. We know it, but sometimes it slips. On a casual basis, I can just tell you when a new year comes. So the first date after 31st December, 1, instead of 23, I write 22. So that is a slip. Now in our case, we turn our back, we want to switch off the gases and then we want to rotate the knob of nitrous oxide. By mistake, I do it with oxygen and nitrous is still going to the patient. So that is a slip. What is this lapse? Again, timing of heparin just before 3 minutes after the surgeon has to have to inform him. Then if I have not given the prophylaxis, that is a lapse. I have not checked the blood, that is a lapse. So memory forgetting. Action-based errors and memory-based errors. So as I said, one is memory, one is action, not switching off the knob and not giving the prophylaxis when it was to be done. Definitions to be understood: that the occurrence of an error. What is a near miss? Occurrence of an error that did not result in a harm. As I said, I checked the blood, I checked the name, I checked the middle name, I checked the surname, and then the blood group. So it was a very, very close miss. By mistake, one small mistake, and we would have had it, the whole OT complex. Slip. A failure to execute an action due to routine behavior being there. That is, I wanted to shut off nitrous oxide, but I shut off the oxygen. So that is a slip. Lapse, a failure to execute an action due to lapse in memory. Antibiotic prophylaxis, I forgot to give. Then medical error. Now, or the failure of a planned action to be completed or intended, or the use of a wrong plan to achieve an end. Simple. This is quite simple. Even not keeping an airway, not planning for a nasal intubation, not talking to the patient, informed consent is again a medical error. That patient should be informed की आता मी हा ब्लॉक देणार आहे तुम्हाला, ही सुई दिल्यावर तुम्हाला कुठेतरी मुंग्या जाणवेल, करंट येईल. So it has to be informed. Medication error. An error in the medication process, whether there are adverse consequences or not. This is what we are learning. Now, what is adverse drug event? Here, my dose is perfect. My drug is perfect. What went wrong is the sensitivity of the patient. So he reacted it otherwise. For the same dose, my other patient will not have any reaction, but this patient has a sensitivity and he will develop rash. So adverse drug, preventable, harm that could have avoided through reasonable planning. So if I know the patient is allergic, if I take a good history, I come to know he is allergic to this and then avoid giving them. So preventable adverse drug events. Slide is okay. So these are the adverse reactions. Example I said, you inject something which is regularly and routinely done, but the patient develops an adverse reaction. Now, these are very, very important. We are well versed it. We have stickers which are to be labeled or to be pasted on the syringes directly. And these are the color coded standardization of the color code by national and international standards. So the induction agents, they come in a yellow vial, muscle relaxants red, narcotics opioids blue, vasopressors come in purple, anticholinergics green, reversal agent pink, and local anesthetic light brown. This is universal, but still there are new companies coming and they have varied color coordination which may confuse as such. So it is always better to be vigilant, read it and then go ahead. Now problem solving. We have seen what can happen. Now how to avoid them. So check labels before drawing up. We are doing this, but to be more vigilant, we can use a lens as I said. The font sizes become very small and similar sound and similar looking drugs. Standardization of font, size, color, and the information included. Labeling of syringes. We can code definitely by the syringe position. We have a habit of keeping the depolarizing agent usually on the near the monitor in a horizontal position. Or we can have a size of the needle, like 2 cc is for succinylcholine, 10 cc is for my induction agent, 5 cc is more for sedation. We do this. Tidiness. Yes, being organized. I finish a case. I have to hurry to a next case. My next patient is already coming. And I forget, I finish, I aspirate, I'm done with it. Suction is lying somewhere. And my bins, what container is also there on the table. It is a good habit to place whatever and not throw it. Keep it there so that what has to be given, what is given, you know it. And then after I have finished, I have to move to the next case. And suddenly a patient comes or the same patient develops a complications. And my trolley is not tidy. It adds to our panic moment, our anxiety, and we may again go wrong. So tidiness or keeping the trolley organized is equally important. Separation of similar or dangerous drugs. Here I can again quote a case here, particularly when we are called for CT scan or MRI centers. Now there many a times we don't need schooling. If the dangerous drug is kept in the center or even in the ICU, and we get a call, or not us, but somebody else is there, and by chance, instead of contrast, a scoline is given, imagine what can happen. So separation of similar and dangerous drugs. This technique is coming up, though costly, but it is going to be helpful in the long run. Barcode reading. On every ampule, there will be a barcode reading, which is linked to the computer before drawing up. Some more tips. Errors should be reported and reviewed. Clinical audits should happen in the hospital, and we should be proudly going to the audits because our inputs are very important. We are the ones who face the emergency. We are the ones who are called for an emergency tackling. So clinical audits should be attended. No blame game has to be there. What went wrong and how can it be corrected? More than who did it, who was wrong. No, this is not to be discussed. So clinical audits. Coming up are pre-filled syringes, at least for emergency drugs, so that you don't draw up and we don't waste time in dilution, that correcting of the dose or dilution, we don't waste time. So pre-filled syringes is an option for at least emergency drugs. Drugs should be drawn up and labeled by the anesthetist. Color coding should be agreed. National and international standardization, as I showed you. No disturbing colleagues in the next room. Yes, in a multi-complex, particularly while maintenance of anesthesia. I have finished with my first induction and extubation also I'm quite alert. But during maintenance, I try to go and visit the second theater. That disturbs, that displaces whatever is going in the mind of that patient or that of that anesthesiologist for. So no disturbing colleagues in the next room. How can we provide solutions? Yes, this is happening. Now, injection gentamicin has this yellow label already on it, showing that gentamicin is contraindicated in myasthenia gravis. Maximum dose will be 450 milligram 24 hours. This is a good method to avoid errors. Containers, lines to be labeled from the OT going to the ward, from the CT scan center going somewhere else. So everything has to be labeled. Medications to be labeled in details that will accompany patients. What has to be written on the labels? Patient's full name, active ingredient or medicine added to the bag, units, what is added to the bag, volume, the concentration, date and time, prepared by, checked by, and the route of administration. Particularly for us, IV and epidural. So it is very important to label whatever is being going from the OT to the ward. Now, this is again a new concept, very well concept to be still coming back to us, Venron. Currently, all our syringe ports on the fluid delivery system are able to interlock with any syringe nozzle, anything. So thus we are predisposing to occur an error here. Now, Venron possesses one syringe port for each of the 7 most common categories used in anesthesia. I'll show you a picture. See, now this is that central port which is provided by Venron. Full form of Venron comes like V for vasopressin, emergency drugs, E, induction agents, iron. So Ven, ROM, reversal agents, opioids, and miscellaneous. So Venron, this is that port which they have started, and every nozzle will be different for a different syringe. So all these chances of making an error are tried to be less in this case. Everybody is working for that same thing. So this is a good concept going on Venron. Very important slide again. People who make mistakes, not only in OT or us, everybody of us. And very, very small part of us admit, yes, I made a mistake. How many of us report? First, I have to admit, yes, I made a mistake. Then I have to report, and then I have to work on it. Like this report, this mistake should not be repeated by others. Why should we document? Why should we report? It can act as a preventive measure and can be a guideline for others. Now, possible management. Error has occurred. What to be done? Training of anesthesiologists begins with preparation, labeling, arranging drugs before start of a case. So there are no shortcuts to this. Vigilance. It is seen as our ISA emblem also. Vigilance is very, very important, especially during maintenance of anesthesia. Stress-free operation theater. Atmosphere. Very correctly said again here. Chaos. The surgeon is annoyed. You are late. Surgeon has come late. You get angry, shouting on the ill OT assistant. He did not come in time. No, actually, what I do in my OT is we play a soft music. We ask, even talking to the patient is very important. His anxiety levels, his stress level. Verbal anesthesia, vocal anesthesia is equally important. So that also plays a role. So stress-free operation atmosphere is important. Now, what will you do when things go wrong? Very important again. To inform the patient and the relatives in a closed door meeting. Give adequate time to allow the issues to set in. Spend time without phone disturbances. When in panic, we tend to call up people. Now, this is a what should I do? My close friends, of course, but then give some time to self also and talk to people responsible and explain them. Don't fail to administer the correct medication and treatment. Yes, many a times even disconnection of the tube while shifting, while changing position occurs. And we fail to understand ki what has gone wrong. We think that the alarms are telling us something continuously, this error is there in the machine. But no, pay attention to the alarms, treat them, correct them. Openly offer second opinion to patient and relatives. Now, here I would ask your secretary, Sir Dr. Chandolkar, only to highlight us. Report to the National Drug Safety. This is the website. We can report, audit it, implement safety measures and reevaluate it, notify medical indemnity, of course, in case of fatalities, and seek guidance from your seniors. Second part, again, our National ISA Registry, Dr. Naveen Malhotra sir has also helped us a lot. He has created this ISA National app. I have also downloaded it, and we can report here anonymously. We are not, it is not necessary for us to put down our name. We have, this comes again positively. That one is your drug errors you are reporting, mistakes should not be done by others, so that it is a guideline and a preventive measures. Also, the number data collected in private practice. So ISA National Registry is a very good option come to us lately. From the session, I will say a take home message. No anesthesiologist intentionally makes a mistake. Yes, we don't want to do this. We don't want to cause any harm to the patient. Support him, her, be vigilant, report, and prevent errors. Again, I would like to conclude, one who is alert can save life. Daksho Rakshiti Jivita. Thank you.
Thank you. Thank you, Nikita.
Yes, I hope I have done justice to your topic and medico legally.
Yeah, you covered almost everything, and ours is a motto because this month our ISA National started registry of every case and other thing you mentioned in your last two slides. And our academic committee, even our ISA members also think that. So this one is the awareness program for that. Our ISA app started, and you should mention your every case details, and any mishaps happen, you should register in that. So very much thank you, Nikita. Uh, One case I want to share with you. It's an open platform. Nothing that same color coding was there, and I used to give tramadol sometime or sometime people sick, but somehow in that case I gave bucuresic almost to CC. I was discussing
And you were
on
very, very wise enough to
close
share
my
it with us.
yes,
So
yes, yes.
you
So
get help. You have to admit the error and report it and discuss.
yes. That was, but by God grace, nothing happened. And after that, I am very much alert on that issues. So you clearly mentioned that you should use phones Zoom if you don't have any lenses in OT. Yes, that's a very practical thing you mentioned in your talk.
It helps a lot actually.
Really,
My
it
case,
helps a lot.
COPD, I picked up fentanyl myself, and patient was on BiPAP initially and had to come to the OT. And that single mistake would have caused a major harm. So it has to be checked every time, Zoom or whatever. To see through the lens of it.
Mhm. Think today a lot of our Nara gang and a lot of members from ISA societies today joined, and everybody was really, I think, helpful with this talk. That anybody having question, please put your question answer box. Any question?
Actually, I cannot see.
Yeah. Nowadays,
You are also a better judge actually.
a lot of yes.
Hmm.
Yes, yes. Nowadays, a lot of color coding, what we experience in these days, that's not happening in nowadays. That related to mostly neon, that same white paper, and that I send you that photo also. Color post tramadol and one other thing. What is it on like? So they are
Standardization is
saying
not being followed.
5%.
Even the font size and many drug and pharma companies coming and putting up their products.
Also in areas also this is very popular brand, and we are using almost everything from neon. So they should, I think, keep color coding, but I think they should use if
You are muted, Sachin.
yeah. Yes, madam, just so heartily congratulations, Nikita, for an excellent talk. Thank you, ma'am. Congratulations for Nanded and for me. Thanks.
I am learning
I
from
feel
definitely. This was a learning experience for me too. And
yes, yes, yes.
very good.
All are yes, yes. All are in learning phases, and we should. I generally keeping topic for private forum point of view only, because we are not in academic touch regularly. So due to this, people will, and we are uploading these videos on YouTube, so they can hear these videos regularly. And excellent response is happening on YouTube also.
Yes. Nice. Congratulations for you, Team Nanded. Actually, we have a question here. One will avoid reporting
Uh,
serious drug errors like Tranexa in spinal. Does this reporting? Yes, sir. It has an anomaly. You can. ISA National, our ISA National only has provided that you just report it and there is no need to put down your name. It can be done. Your name can be still anonymous. Actually, it is going to help others. Even after giving that drug, what symptoms you saw, you should be reporting. So whenever a patient is seen like that or a mistake, then you are vigilant. He is developing convulsions or lower limb paralysis is seen lower. So I also know something is wrong. Then I check my ampule. Accordingly, I can correct also. So yes, we can and we should report it without a name is fine. Always I say it is not the one who has committed the mistake, but what mistake has been done has to be audited.
yes, yes. I think overall session is good and no questions. In, okay, one more
Everybody is
question, please.
introspecting, I think.
I think
We are
yeah,
all
yeah.
introverted, yes.
And I mean
Everybody,
somewhat busy
nobody wants
in
to commit
technical because of
mistake. No.
net
Everybody wants
issues.
for patient safety.
Yes,
Also.
yes.
All of us, definitely. Do we have questions in the chat box?
Yeah, yeah. From Dr. Shashi Patil, sir, he is asking, do you need to report the mistakes in the notes of the patient? It's it's a, I think it's medical legal part, but madam will say on this, please.
It can be actually the patient has to be informed, and patients are now they are also well educated and reading every bit, so they also know what went wrong. Even simple OPD basis, you prescribe them drug, they will ask you these are the side effects. Am I okay? Should I take it? Can this be avoided? So putting it down before that, sir, I will say that we have to discuss in ourselves, our close contact, take notice and then put it down on paper so that if it is a adverse drug reaction, then it can be avoided in the next cases. And if it has to be in our clinical audit, we can discuss it. But now putting up this error that this instead of this a blood was given or this was not given, the tube disconnected, this has not to be put up. One more question is there from Sai Madam. Was spinal lavage discussed in tranexamic acid intrathecal injection? Is it mentioned? Here we have discussed this tranexamic acid injection and reporting. Do we report it? Whatever the treatment line has to be done, yes, it has to be done. You have to work on that patient, and it is always for the patient safety. But reporting or not reporting was the question. So we observe and intervention, whatever has occurred, we will have to document. And so the cause comes into picture. Because we are observing or we are doing the interventions for this case, we have to put it down on paper. Yes, this wrong injection was given, and that is why we are observing and intervention is being done. Because many times we have to go for a scan or MRI or even extra monitoring, ventilation. So we'll have to. Medico legally, what would you say, Dr. Chandolkar? Dr. Sachin?
It's any mistake you are doing. It's not a mistake. It's you can say it's complication. It's not a mistake. But in human error type of like exchange of another drug instead of this drug. This is human error. If you want to take down on your paper, it may be nowadays it's very difficult to also. Nobody will listen these things in the court of law. So you can register in our ISA forum, but not on paper. I feel so.
Yes, very true. Because we have treated it, but for others to learn from our mistake, we have to put it on National ISA Registry. Another question in the chat box from Dr. Abhijit. Yes, Abhijit. I think Molatra sir is already working on it currently, and next also step can be done. The font size to the companies have to be informed that we need a standard labeling, standard colors, standard font on the labels, and repeated, like many companies coming up with this look alike, sound alike. So we have to be very vigilant for that. We can do it together through the national platform. Yes, definitely.
Yes. Through national, it will happen with strong leadership. This will definitely happen on grassroots levels.
Actually, that is the only reason we have to report. If they don't get a complaint or we are not reporting, how will they know?
Yes. Then only they will recognize that this is a major issue in day-to-day life of anesthesiology. Then only they will adjust or maybe correct their problems with ampoules. One question from I think Anil Gadgil: how do I save your skin if report to patient? Also, what I'm not getting this question.
Actually, he's asking us if I document it or reveal it to the patient, then how will I save myself? Because patient, he will pass it on. He will himself try to do so many judgments. Then his relatives come in picture, his friends come in picture, and the software.
Okay.
So how do we go about it? Yes, sir. If
yes,
things are going to be
same question.
We can tell them in a subtle way कि this has gone wrong, or that is why patient has headache. Let me observe us. We are treating. We are going about trying to investigate what has gone wrong. If simple post panel, even headache, we cannot tell them directly because I punctured the dura and so patient is having headache. That I cannot reveal definitely. So I will not tell the patient. But if it comes to the category I have to tell them what went wrong. If it is a death, so that time maybe we'll have to reveal everything to the patient as well as put it on paper. When there is harm occurred and the patient can be saved, we don't put it on paper or to the patient.
No. Dr. Shashi Patil is asking, if mistaken drug given but managed properly, do you need to join pen down in the notes? Because if some medical legal issues is raised, one way you are admitted your mistake, which can be taken as an evidence against you.
That is what
was the.
No. We don't put it on paper. We take it to the audit in our own hospital for our safety and for prevention, not on paper with the patient. Patient is very, very aware, and with the insurance company coming everywhere, they can sue us and ask us for a compensation. So no, we don't tell the patient or put it on paper. But sometimes if things have gone wrong completely, then we can modify, we talk to our seniors. That is what we said, how to correct it. So what can be put up? In fact, we are, even if we have done wrong, I can talk on this platform only here. If I have done a mistake and because of my mistake even the patient has, then I'll have to cover up. I have to see, I have to preserve the ampules, put the notes properly, and try to see that some emergency or some reaction or something else has occurred which added to this fatality and not my mistake. I'll have to put up to save my skin. That is right.
Yeah, if you are managed very well, then you can put your mistake on paper, and maybe it's a what I say pramanik panaf. To me, you did it, and maybe court of law will hear you sincerely that you did that mistake, and you recognize that mistake, and you rectify that mistake for the safety of patient. Then it's okay. You can do that, and you can even explain to relatives also on that note also.
In a closed meeting perhaps, but we can avoid only, I think, because patient comes up, then he talks to somebody else, he tells us. I actually told you when I started reading about this topic and the medical legal error, my first slide, first thing comes to us, our mind is the law. Then we see what went wrong and how to correct it.
I think it's age thing that to be or not to be like a situation now. If you did and you rectify it, and you should pen down or not. Really, it's but from court of law, if you think, then nowadays in district court also 1 CR is there, compensation point of view, and state level 10. So you think before that, what can you afford? From my point of view, I feel so. If you able to do that much, because nobody will listen then that you did or not. A lot of cases happen in even out of country, US, UK, like that, their situation. They clearly mention human error, and it's taken for granted.
Very, very difficult in our settings, I think, our country
Yeah, yeah.
first. Second,
Yes,
we'll
yes,
have
yes.
to speak up to our seniors, or even we should have our colleagues who are in this. Like in our case, we have a friends, or we talk to our friends in the civil hospital who can guide us how to go about it. If a fatality has occurred, first these are the ones who are informed, and then how to go about the channel is also taken. We take information or the ideas, or even the right channels. They guide us how to go about it, and we can come ahead of the problem.
I feel lot of issues discussed, and maybe it will go ahead with the medical legal point of view now, if we continue with. But in drug error point of view, I feel so that every viewer will discuss their issues with you and us, that what point there is mainly fatigue, and what we say, hurry in OTs. That happens mistakes most of the time, because of you're come for one case and hurriedly going for next case, or you are nowadays due to phone also, a lot of phone calls coming in OT also. That is also one of the main reason for drug errors, for private forum point of view, even in academic, in society, institute point of view also.
Yes, and actually in corporate hospitals, even the institutes, we don't report it to the patient many a times. Private practice, so it is totally different. But even at that level, but they have internal review and learning. For that, we have to report it to ourselves, or in the not to the patient but to ourselves. I mean, in our system, we have to report it, because maybe now see, last few days back we had that propofol case coming up. Because they informed or they reported it, we have come to now, we are also vigilant which brand we are using, why this drug was used, and because it came from a common store. So that helps us to be again next time, how was the culprit actually propofol? Even we don't know that, but now we are vigilant before using a drug. Even every antibiotic, although the patient is already receiving antibiotics, we do antibiotic sensitivity test every time we inject. Local anesthetic sensitivity is different thing. Again, we have to test. History taking, of course, allergic components, and then what to be prepared with if I have anaphylaxis or emergency drugs. That is again, that has been taught to us as our training. So these are to be taken care of. It has to be discussed mainly, and so the cause is found out, and then it can be treated and next reported and prevented. So the cycle is like that.
Yes, yes. In corporate point of view, you mentioned very well that there is internal audit and all these things. But for private forum point of view, how private practitioners do internal audit with their colleagues or their
We talk to a
in
close
between the
group.
society branch or
Yes, we
with
talk to
the
a close group of friends, we discuss it. Then so many cases which I have put up here, they have actually happened. There was not a single case which was, I will again tell you one more case in CT scan center very, very recently. Instead of contrast, 10 ml contrast, scoline was given, the patient died. So keeping the dangerous drugs in the not wrong thing. So everybody, pneumococcal vaccine was to be given. Patient was given pancuronium. This has also happened directly. The titles from the dispensing, like from the medical pharmacy, also the dispensing goes wrong and things. Who is administering the drugs? That makes a difference. Any more questions?
so
Questions are seen.
I feel no questions from audience. Any? So I feel I will conclude this session with thank you, thank you once again. That for a very short notice you agreed with this topic and really you did very well. And a number of people also increased today's session also. Um, so I feel that
You gave me was very important. That has raised the number definitely.
yes, and you are
So
one of the
congratulations to you, team Nanded. Very well doing. Throughout the tenure, I'm seeing Sachin is very, very busy. Still, he's managing so many things. Congratulations. You deserve it.
thank you, thank you. So I will conclude this session.
Sir also.
Thanks a lot.
Thank you so much.
Thank
Thank you, everybody who logged in. I hope we have benefited. We'll definitely report cases, at least among ourselves. We have so many groups. We have to discuss and report so that these errors are avoided. Thank you so much.
Guys, we are keeping one extra case meet on Sunday after we are doing routine Friday case meets. How to choose right indemnity insurance and need of the hour on Sunday evening 6 p.m. That will be shared with all of you. And thanks for joining today's evening. This is our Silver Jubilee year of City Branch and Platinum Jubilee year of our ISA National. So we are conducting this case meet. So do join regularly on Friday evening 8 o'clock. Thank you. Thank you a lot.
Thank you very much.